Exodontia means extraction. Now, when can we go for routine extraction or the simple extraction and surgical extraction? Now, if we find that the tooth is badly broken and we cannot have a good grip over the tooth, we go for a surgical extraction. Surgical extraction includes flaps, includes suturing, includes bone removal, and so on. Now, is extraction a matter of force? No. We gently lift the tooth out of the socket. We do not apply pressure. We do not, it's not about muscles. So, extraction of teeth, it's not about muscles, it's about being careful with the bone and the teeth and extracting them gently, lifting them out of the. Now, it's not about force, it's about gently lifting the tooth out of the socket. So, I try always to make the tooth as much mobile as I can. Then I will lift it easily out of the socket, not applying pressure because pressure will cause fractures of the root, fractures of the bone. So, no, we just make it mobile as much as we can and then we remove the tooth. So, gently we just lift it out of the socket. Now, what are the indications for extractions? Caries. So, every caries teeth needs extraction? No. Badly decayed teeth need extraction. Pulpal necrosis. If the tooth has pulpal necrosis and it's not endotreatable, we can go for extraction. Periodontal disease, when we have grade 3 mobility or non-restorable teeth deemed by periodontal assessment, we need to go for extraction. Orthodontic reasons, we need to be very careful with them and we need to count the teeth because sometimes we talked about it in the complications lecture. We said that we must count the teeth because sometimes we can extract the wrong tooth. But otherwise, we need to be careful with these teeth because a remaining root, a remaining piece of the tooth will be a problem for ortho. So we try to do our procedure as safe as we can. Other than that, back in the day, they thought that late lower incisor crowding was due to the lower wisdom teeth. So a lot of patients had their wisdoms extracted due to the uh, lower incisors crowding. But then they found out that the wisdom teeth have no effect on this. It's just a myth. So no, late lower incisor crowding happens because of the mesial movement of the teeth. Without the wisdom teeth, if they're not present, they will still move, and it will happen in the late 20s. So always, we do not extract wisdom teeth for late lower incisor crowding. But we can extract them for orthodontic reasons as distalization of lower molars. We can extract the wisdoms if they want to distalize the 7. And orthognathic surgery, 6 to 9 months before the surgery or during the surgery. Malpose teeth, teeth that are not in their right position, supernumerary teeth or extra teeth, extract cracked teeth, teeth that have vertical root fractures, impacted teeth, teeth that have pathology like cysts and all that. Radiation therapy. Do you need to extract all teeth in relation to radiation therapy? Or what? Why is it an indication? Now, sometimes patients, a lot of people, sorry, a lot of patients will be referred to a dentist to see the teeth. These patients have maybe thyroid cancers, colon cancers, and they're about to start radiation and chemotherapy. So we need to be careful and we need to see the teeth. Any teeth in questionable prognosis, we need to extract them. Because these patients cannot undergo extraction later on. If the tooth fails, they cannot undergo extraction. So we need to extract them before. Because after radiation therapy, we have the risk of osteonecrosis of the jaws, and we have the risk of MRONJ or bronch if they took chemotherapy or any other types of medications. So before radiation therapy, we need to extract the teeth. Now, usually we prefer to extract them 3 weeks before the initiation of the therapy. So soft tissue healing can happen, bone healing can happen, and everything can be within the control and in good terms. Teeth involved in jaw fractures. All teeth? No. Only teeth that are broken, like they have a crack in them, there is a separation of the tooth, mobility, infection, and they interfere with reduction. We cannot reduce the fracture back to its original alignment, so we need to extract them here. But otherwise, if the tooth is not interfering with our reduction, no infection, no mobility, we keep them and we do the plates while they're present. Sometimes financial issues. Sometimes the tooth is in questionable prognosis to fair, like the tooth needs endo treatment, but the patient cannot pay for it, so they can undergo extraction. Now this goes back to the dentist. Sometimes some dentists do not approve extracting a restorable tooth. That's up to them. Some dentists can extract it. That's up to them as well. So this is one of the indications for extraction. Now, here we can see ortho referred the fours for extraction. We need to count them. Central, lateral, canine 4. Here we have remaining roots. Here we have badly decayed tooth. And here we have an impacted tooth. Now, what are the contraindications for extraction? Like systemic causes or local causes. Systemic, poor medical status like poorly controlled DM, hypertension, leukemia. If it's uncontrolled, we do not do extraction. Pregnancy is a relative contraindication, meaning in the first trimester and the third trimester, we prefer not to do any elective procedures. In the second trimester, we can do our procedures. We can do implants in them. It's fine. Medications. Some patients with bisphosphonates, the IV bisphosphonates patients have, this is an absolute contraindication for extraction. IV bisphosphonates, absolute contraindication. Even if the tooth is remaining root like this, we try to do endo for them, because if we do extraction, we will end up with medication-related osteonecrosis of the jaws. And this will be very difficult to manage. Local factors like radiation therapy, we need to ask the patient if he had the neck collar on or not. If they had the neck collar and the apron, we can do a procedure. If not, we cannot. Pericoronitis, tumor. Now, we cannot extract if there's a tumor. If it's involving soft tissue or bone. Meaning, if we have a local tumor, if we have an active malignant tumor, if we see something that looks malignant, we prefer not to extract. We keep it, we do resection, and that's how we extract this tooth. Even if it has mobility, even if it has infection, we keep it and do resection because it has a malignant tumor surrounding it. Acute infection, it's a myth. Now, we need to think about it. We cannot have healing without removal of the cause. So as long as the cause is present, as long as the cause of the infection, which is the tooth, is present, there will still be infection. So, what we do in these situations, we extract the tooth, give antibiotics with it, and that's it. It's not a contraindication for extraction. Now, what's difficult here is anesthesia. So it will be difficult to anesthetize the patient. Patients will still have pain sometimes while extracting, but it's the only way to resolve the problem. Sometimes you can go for general anesthesia to extract the teeth and do incision and drainage, and so on. So clinical evaluation, we need to assess mouth opening. We need to assess the condition of the crown, and we need to assess mobility. Now, if the patient has a mouth opening of 20 millimeters, here I cannot do extraction for him because I need him to open wider. Now, let's say the patient has an infection. This is an indication for tube, GA. Mobility, if it's mobile, it's going to be easier to extract. And a condition of the crown like this, I will not guess that this tooth will be extracted easily, so I will go for surgical extraction. Then we need to assess the radiographic evaluation of the teeth. Now here we have these two teeth. Which one do you think is easier to extract? Let's look at both pictures. Here we have an x-ray. We have a wide periodontal ligament space. This tooth is mostly mobile with an infection, so this one is very easy to extract. Here we have a retained deciduous tooth without any permanent tooth causing resorption of the roots, so this one will be very difficult to extract. Sometimes you might do separation for this tooth to extract it, especially that the 4 and the 6 have moved to close the space between it. So here, for example, the condition of the crown. So here, I will suspect that this, once I hold it with the forceps, it will be fractured. So I will go for separation and then extract the tooth. Here, same thing, bad decay. Once I try to hold it, it will be fractured. So I will need to go for separation and very careful extraction. So in these two cases, I will go for surgical extraction. Now, distance to vital structures. Here we can see that this tooth is very close to the ID canal. So here I might go for separation, bone guttering, the removal of the bone a very good amount, so I can extract the teeth easily. So always we need to look for vital structures. Now sometimes we have abnormal configuration like dilacerated roots, hypercementosis by 2 roots or 3 roots in the tooth, octopus-like tooth. Always the most difficult tooth to extract is a lone wolf, a tooth that has been present in the oral cavity for quite some time and we cannot remove it easily because we have the 6 and the 7 not present, so this tooth will have all the forces. The roots will be very sticky to the bone and they will be very difficult to extract. It's going to be extremely difficult and bad. Now sometimes previous treatment. Endo-treated teeth are very difficult to extract because they will be very fragile. Here for example, resorbed tooth. This is a very bad situation. It's going to be very difficult to extract. Associated pathology like internal resorption. This might cause a crack in this area, so you can have this piece remaining. Now, are these teeth indicated for extraction? I don't think so. They can be endo-treatable. Now, how to manage the patient for extraction? First, universal precautions. We can ask the patient to have antiseptic mouthwash before. We can have lung protection. A loose 4x4 goes on the posterior part of the mouth, so the tooth goes back, or we lose the tooth, or it slips from our hand. The gauze catches it, and then we can prevent aspiration or any other problems. Now, chair position for extraction. In maxillary teeth, the chair or the patient should be between in the maxillary, for maxillary extraction, at or below the operator's elbow level. For mandibular extractions, more upright position, so it's between the shoulder to the elbow. So here for maxillary extractions at the level of the elbow or below it. Here for mandibular extraction above the elbow slightly. Now when we do extraction, the first sequence we do is that upper before lower, so we can control the bleeding above and prevent it from dropping downward. So if we extract the lower teeth first, then we extract the upper, some drops from the blood can go into the lower sockets. So this can cause infections if there is an infection in this area. Posterior teeth before anterior teeth. Now, the canine and the upper six, or the first molar, these are the most difficult teeth to extract, so we keep them last. Meaning, we extract the 8, we extract the 7, we extract the 5, then we go to the 6. Then we extract the 4 and the 2, then we extract the 3. So we can lose them from both sides, so the tooth can be easily mobilized and out of the bowl. Now, elevators, the function of them is luxation, only to mobilize the tooth. So we have the straight elevator, which does wedging effect. It comes between the tooth and the bone. Now this is a very big mistake I see in newly graduates. They just put the elevator and start moving it, wiggling it in place. No, we need to visualize, see where the bone and the tooth are separate, where they attach to each other, and that's where we place our elevator, between the tooth and the bone. So it can function, it's wedging effect. Now, the Cryer's elevator, they function with the wheel and axle. The wheel and axle movement. It enters and then we remove the tooth, the remaining root from its side. For forceps, we widen the tooth sockets and then we can deliver the tooth with it. For maxillary central incisors, lateral incisors, and lower premolars, the function is rotation. That's how we extract these teeth. Rotation only, nothing more. Rotate the tooth in place and then we can get it out without buccal and lingual movement. But the first movement we do is apical pressure. So we can cut the periodontal ligaments and then we start rotation. For the canine, first apical pressure, then buccal, lingual, and then rotation to get the tooth out. For the maxillary first premolar, the king of fractures, first apical pressure, buccal, lingual. Now we need to wiggle the tooth from its position and remove it so we don't fracture one of the roots. So we try buccally, lingually with downward pressure, buccally, lingually with downward pressure, so we can get the two roots out of their place and prevent fractures. For the second premolar, same thing, apical, buccal, lingual. For maxillary molars, sometimes figure of 8 motion. Apical pressure, buccal, lingual, rotation so we can get the roots out of their sockets, and then we deliver the tooth. For mandibular incisors, buccal, lingual movement. Mandibular molars, also figure of 8 motion. And for the premolars, as we said, rotation. Now, we talked about post-extraction care. We debride it only if necessary. The expanded buccal plate should be compressed, but this was an old school. Now we do not do that because sometimes we can fracture the plates and prevent the placement of implants. We remove any sharp edges and apply 2x2 inch gauze. Here we see an extracted remaining root with a lesion surrounding it. And here we can see the x-ray after extraction of roots. Here, an upper wisdom. The root tip got fractured, but still attached. So here, we can say الوالدة داعية إلنا. Always when it happens and the fractured piece comes with the tooth, that's luck. You can't do anything about it. If it's fractured and very small, we can leave it in place. So yeah, that's kind of luck somehow. So now we'll talk about complex exodontia or surgical extraction. Now, so when do we go for surgical extraction? Now, we can call it complex exodontia, transalveolar extraction, surgical extraction, open extraction. All of those are synonyms to the same thing, surgical extraction. Okay? Now, what are the indications? First, abnormal anatomy, dilacerations, tooth close to the sinus, large restoration, long wolf, hypercementosis. These are indications for surgical extraction. Impacted teeth are indications for surgical extraction. Badly broken teeth, undertreated teeth, these are indications for surgical extraction. So all when we see there's big cavity, big restoration, root canal treated tooth, these are we difficult to extract simple because we need to think that these teeth can be fractured, can be fragile, so we need to be very careful when we remove them. So what is a flap? It indicates that we have a soft tissue incision, meaning we open it with a blade, we close it with suture, it carries its own blood supply, we can see the underlying tissue, and we can replace it into original position again. Now, principles when we want to open a flap. The base of the flap, the base of the flap should be wider than the apex. So this is the base, and this is the apex. The base should be wider because the blood supply comes from above. So we need to have the base wider so it can supply the whole area so we don't end up with necrosis. Okay? Great. Now, we have, if we were doing, this is called sulcular incision. If we want to do a sulcular incision without a releasing incision, a vertical one, we need to do 2 teeth anterior and 1 tooth posterior. If we have a releasing incision, 1 tooth anterior and 1 tooth posterior. Now we need to have good ability to insert our elevators, to insert our instruments, to insert the handpiece, so we need to have good access. A small flap will heal the same as a large flap. So we need to be careful in this. So if we do a long incision, that's fine. If we make a large flap, that's fine. We're going to replace it with sutures, so it's going to be fine in the end. So the most important thing is to remove the tooth with minimal complications, with minimal destruction to adjacent structures. Also, we need to hold the flap out of the surgical field with placing the retractors on intact bone, because if we have soft bone, it can crush it. So we need to place it on intact bone. Now, we do not do releasing incisions in the mandible. Now anteriorly, yes, we can do releasing incisions up to the lateral canine sometimes, but beyond that, no. We do only sulcular incisions, and we make sure that we visualize the mental nerve so we don't do injury to it. In the palate as well, we do not do releasing incisions because the nasopalatine neurovascular bundle and the greater palatine can be injured. Now, sometimes, most of the times, actually 90% of the times, the nasopalatine can be injured and cut, and we just can't do anything about it when we do exposure when we do extraction of an impacted canine. There's nothing to be done. The patient will have paresthesia in the area for quite some time and then he will get used to it. Okay, so no releasing incisions at all. Now, a long straight incision with adequate flap reflection heals more rapidly than a short torn incision. And we have full thickness, so we have mucosa, submucosa, and periosteum. Now we have crystal sulcular flaps or envelope flaps. These are the most commonly used. We have 2 teeth anterior and 1 tooth posterior. We have the 3-cornered, as you can see, 1 corner, 2, and 3. Or 2-sided, 1 side, 2 sides. Now, some people call these triangular flaps. Here we have 1 tooth anterior, 1 tooth posterior. If we have 2 releasing incisions, then we have 4 cornered flaps or 3-sided. We can have semilunar incision if we have a crown, a prosthetic crown, and we have a lesion around the root. We want to do apicectomy, apical surgery, so we do not injure the papilla or the margins. It gives us limited access only to the area that we want. For palatal tori removal, we have the Y incision. So first thing we do is by the blade we cut the periodontal ligaments and then we raise the flap like this, with the small end of the periosteal elevator, then with the wide one to raise the flap. Now, when do we remove bone? That's the most important thing. Now, sometimes I open the flap. I can see now. If I see a lot of bone around the tooth and I don't have any place for my elevator, I need to remove a small amount of bone mesially and distally to remove the tooth. Sometimes, once I open the flap, I can see the root and I can hold it. I can have good grip over it. So this will make me apply my forceps. Sometimes I can fracture the buccal plate, small piece of the buccal plate, with the tooth and remove the tooth out. Now, techniques. If we have a multi-rooted teeth, we do separation. In the lower, we do in the center. Then we fracture them with the elevator, separate them. We always leave a little piece at the end to fracture with the elevator so we don't injure the lingual nerve. And then with the Cryer's elevator, we can remove them. So here's the case. We do surgical extraction, each root removed alone. For the maxillary extraction, we remove them in 3 pieces. 3 roots, each one alone. Sometimes you can remove the crown with one of the roots. Now let's say while we're doing extraction, we had a fractured tip. Now a root tip is up the apical part, 3 to 4 millimeters. Now, if it's non-small, non-infected, stable, associated with vital structures, covered with bone, we need to leave it as it is. Just tell the patient about it, have periodic x-rays, and that's it. If we want to go for extraction, we can go closed techniques, which means we do a visualization with the suction and proper light, and then we take an x-ray to see where the root is. We can put the irrigation or the root pick elevator and start to remove it easily. If not, we go for surgical extraction and remove all the bone around it so we can remove it. So here's the root pick elevator. Now sometimes, especially in the maxillary premolars, while putting the elevator vertically, we can push it and fracture the inferior wall of the sinus and the tooth can go into the sinus. This is very risky, so always we try to remove bone around it, hold it, push it downward, not upward. Here, for example, we have a remaining root. we remove buccal bone around it as much as we can, mesially and distally, and then we remove the tooth towards our direction, buccally, so we can hold it. We can see it when we remove it. We need to inform the patient, radiographic documentation, periodic follow-up, and if there are any problems, the patient should inform us and tell us. Now, multiple extractions, we need to plan. If the patient wants to go for denture, then I need to put some pressure around the buccal and lingual plates after I do the extraction. If he wants to go for implants, no, I do not do that. Suturing, we need to remove alveoloplasty to remove any sharp edges of the bone. Now, in these cases, we might go for continuous suturing. Why? Because it's easier and much faster. But the problem in continuous suturing, if one fails, they all fail. So here we can see some flaps, as we can see here, the mental nerve between the plates. Here I had a tear with the exposure of the canine, so I had to make a releasing incision. Always I either involve the papilla or do not involve it. So in the middle of the papilla, no, I do not do an incision because it will be necrosed. So either I involve it and I open the flap after it, or I do not involve it and open the flap before it. Here for a wisdom tooth and here for an impacted lower 5. Here we can see impacted mesidens that we had to extract, and this one a wisdom tooth with a cyst surrounding it. So this is the end of the lecture. I hope you had a fun time. I hope you enjoyed it and had some good information from it. So thank you.